to welcome everyone, and thank you so much for joining us today. I'm Gina Reganini. I'm the Director of Educational Initiatives in Alumni Relations, and I'm so excited to welcome everyone to our virtual session today on teen mental health. We're so grateful to have two of Northeastern's stellar faculty members joining us today to share the work they're doing to understand teen mental health and make an impact among today's young people. Before I introduce them, a bit of housekeeping. Please feel free to add your questions to the chat as they come up in your mind, and we'll have time at the end of our speakers' remarks to address them. Also, if you'd like to turn on closed captioning, you can use the menu at the bottom of your screen. And on to our introductions. We'll first hear from Dr. Alexandra Rodman, Assistant Professor in the Department of Psychology. Dr. Rodman completed her PhD in Psychology and Clinical Science and postdoctoral fellowship at Harvard University. She completed her clinical internship at the Boston VA and earned her BA in Clinical Psychology at Tufts University. A clinical psychologist by training, Dr. Rodman's interdisciplinary research bridges the disciplines of developmental cognitive neuroscience and clinical science. Her work centers on the social world of teens, examining how social experiences interact with ongoing cognitive and brain development to increase risk for mental health problems during adolescence, a period of heightened vulnerability. More specifically, her research studies how social processing and behavior during adolescence are distinct from children and adults, whether such differences increase risk for mental health problems, and evaluates how social factors can be leveraged to promote resilience in the face of stress. Really fascinating to be able to hear more about that. And next, we're thrilled to welcome Dr. Sue Whitfield-Gabrieli, a scientist, psychologist / neuroscientist, academic, and researcher. She is a professor of psychology, the founding director of the Biomedical Imaging Center at Northeastern University, researcher in the Department of Psychiatry at Mass General Hospital, Harvard Medical School, and a research affiliate of McGovern Institute for Brain Research at Massachusetts Institute of Technology. Dr. Whitfield-Gabrieli's research is focused on the working of the human brain, its development from childhood through adult maturity, the brain's working in neurodevelopmental and neuropsychiatric disorders, and the translation of neuroscience knowledge into treatments. She is involved in the development of neuroimaging analysis methods and software packages, including CNN, REX, and ART. It is my pleasure to introduce our speakers for today. Dr. Rodman, the floor is yours.
Well, thank you so much for that really lovely and generous introduction. I'm so happy to be here speaking with you all. So I'm going to jump right into it. I'm going to give a brief overview of some of the work I've done and our upcoming research happening here at Northeastern in the coming weeks and months. So I'm really excited to present this to you all. So as many of you know, adolescence is a time when so much is changing in the brain, physically, psychologically, and of course, socially. So in addition to taking on new social roles and experiences, adolescents are notoriously preoccupied with peer approval and social belonging. And every interaction can feel more intense, whether that's the excitement of a school dance or the sting of being turned down by your crush. So here in this picture is my 12 or 13-year-old self, but this picture is actually from a group photo shoot for my friend's birthday. And this memory is so incredibly salient for me because I remember feeling like this friend group was really locked in. You know, we had this professional photo shoot and we were going to be best friends forever, right? And that felt really good. But little did I know that these ties wouldn't last and the falling out would be pretty painful and all-consuming. So, I invite you all to think back on your adolescence and feelings of similar, strength and intensity, and ask the question of why is that? What is it about adolescence that makes social experiences so intense? And on some level, it has to do with how teens process social information. So just like any other kind of information processing, we don't just absorb social information as a one-to-one input-output process. Instead, the information we perceive is filtered through our own individualized lenses and is subject to distortion or bias due to prior expectations, motivations, and interpretations. And so when it comes to having varied social experiences that range from positive to negative, like being invited to a party or feeling left out, the way we process those experiences may take different forms, where positive and negative experiences are actually weighted differently. And this weighting really matters because the biased information is then integrated into a more global impression of how we view ourselves, others, and the environment that guide our expectations going forward. And so in my work, I take a developmental perspective and I focus on the age-related differences in social processing, behavior, and experiences to try to understand adolescents' unique social sensitivity and what happens when things go awry. And so the transition from childhood to adolescence, typically occurring around 12, is often described as a period of social reorientation. Adolescents spend less time with their families and more time with their peers. Social belonging becomes increasingly important, where teens are more dependent on each other for support. And meanwhile, social groups are in flux during this time, subjecting adolescents to greater frequency of peer rejection. And this reorientation is accompanied by enhanced intensity of social experiences that can shape emotions, behaviors in meaningful ways. And adolescents are more preoccupied with peer approval, and they show more intense emotion and stress responses following peer rejection. And while rejection is especially common during adolescence, a history of peer rejection has been linked to depression. Indeed, most adolescent mental health problems actually emerge in the aftermath of interpersonal or social stressors, such as being bullied, a romantic breakup, or peer conflict. And at the same time, adolescence is a period of peak risk for the emergence of mental health problems. This is particularly so for depression, anxiety, and suicidal behaviors. At the start of adolescence, the prevalence of mental health disorders is at about 1 to 2%. But by the end of adolescence, this increases to 25 to 30%. And in fact, 75% of all mental health disorders will emerge during the adolescent years. This sharp rise in mental health problems spans many disorders, with the average age for developing any mental illness falling around 15 years old. And importantly, onset at this time tends to have a more severe and lasting prognosis into adulthood. So with all this in mind, clinical and developmental psychologists think of adolescence as a period of vulnerability, when social sensitivity comes at the same time as risk for mental health problems. And this has really profound impacts in society at large, where mental illness is a leading cause of disability among adolescents. And given this risk, it's important to understand the underlying factors that make adolescents especially vulnerable to developing mental illness. And so while I've pointed out the clinical risks associated with this period, there's also tremendous opportunity. Adolescence is when clinical interventions stand to make the biggest impact, ultimately shifting trajectories of risk. And this is due in part to widespread changes in brain structure and function, where the developing brain is making and pruning connections based on life experience. And these ongoing changes contribute to the social sensitivity and clinical risk that we see during adolescence. And at the same time, these dramatic changes lead to enhanced neuroplasticity when the brain is especially responsive to the environment and providing a window of opportunity for intervention. So in my lab, our research is focused on the interplay between these three domains of experiences, neurodevelopment, and psychopathology, where we know substantial change occurs during adolescence. And broadly speaking, we use social experiences as a lens to understand risk for psychopathology during adolescence. And the primary questions that we examine are how adolescents' sensitivity to social experiences may make them especially vulnerable. So this is across adolescence on the whole. And we're also interested in how differences in social processing function as a mechanism of risk for mental health problems, and also how we can leverage social factors to promote resilience in the face of stress. And to answer these questions, I integrate experimental and observational approaches, including behavioral tasks, which help us isolate cognitive processes, neuroimaging to uncover the changing brain and how that contributes to these outcomes, and also digital phenotyping. And this is a technique that involves scraping mobile phone data for objective measures of real-world behavior. This includes things like social media use, call and text logs, and GPS data. And during this period, adolescents, So first I'm going to discuss adolescents' hypersensitivity to social evaluation and the cognitive biases that make them uniquely vulnerable. And as I was saying, during this period, adolescents have to navigate near constant signaling of social signals of inclusion and exclusion, shifting relationships, and they have to use these signals to update future behavior to ensure social belonging. Adolescents are also building up their identity, largely shaped by peer feedback. So information about whether peers like or dislike them may be especially valuable to adolescents. Adults, on the other hand, may not value feedback so much, especially when it's negative. While rejection is a normal part of life, adults have been found to shield themselves from negative feedback, preserving positive self-views. So for example, adults have been shown to blame failure on external factors rather than internal traits. And they also minimize the importance of negative feedback or who it's coming from. And it's unclear if adolescents use these same strategies, and given their rejection sensitivity, it may be the case they haven't yet built up this regulatory response to protect themselves from the effects of peer rejection. So in the first study of this section, I'm going to show you whether adolescents value peer feedback more than adults. And in the second, I'll discuss how adolescents process and integrate peer feedback into global impressions of the self and others. To test this first question, I asked participants to take part in a study about making first impressions, where participants' pictures were rated by other peers. Then participants rated those same peers in return. So there was this rating exchange. And then finally, participants predicted how much they thought each peer would like them. And while we can't measure value directly, we can infer value by drawing upon the framework that individuals work harder for things they value more. So for this study, I adapted a classic physical effort paradigm where participants had to squeeze a hand dynamometer to find out if peers liked them. So on each trial, they were shown a picture of a peer. They squeezed until they reached the threshold to find out whether they were liked. And then if they reached the threshold, they were shown whether the peer liked them. And for the output measure, I used peak grip force, which is how hard people squeezed on each trial. We had a couple of other outcomes that we looked at, but this is the kind of gold standard. We then asked whether expectations of being liked impacted motivation or value of peer feedback. So along the x-axis here at the bottom is participants' expectation of being liked, and then along the y-axis here is participants' grip strength. So first I'm going to show you what adults did. Adults exerted, as you can see, less effort when they expected to be disliked and more effort when they expected to be liked. Whereas adolescents, they did something a little different. We found this age interaction, and what adolescents did is they worked hardest when they expected to be more strongly liked or disliked, but worked the least for neutral feedback or expected neutral feedback. And just to draw this out more similarly, teens valued very negative and very positive feedback about the same, whereas adults worked hardest for positive feedback. And okay, sorry, my mouse got lost for a moment there. So to answer this first question, yes, adolescents valued peer feedback more than adults did, especially when they expected more extreme evaluations, whereas adults were less motivated for feedback when they thought they'd be disliked. And here in this second study, I'll show you what adolescents do with peer feedback once they receive it and how it's integrated into views of the self and others. So similar to the previous study, I asked participants to complete this first impressions task and rating exchange between participants and peers. Then they completed this social evaluation task while undergoing fMRI. So when shown a picture of each peer, participants had to predict whether they were liked, and that would be displayed on the left. And then they were shown what the peer said on the right. And to find out how peer acceptance and rejection impacted impressions of the self and others, we had participants complete a self-esteem questionnaire before and after the task. And they also re-rated the likability of all the peers following the task. So first I'll show you how peer feedback impacted self-views. Findings revealed a nonlinear age pattern where receiving equal parts acceptance and rejection resulted in a drop in self-views in adolescents, but a boost in self-views in adults, which is a bit curious, and I'll speak to that a little later. And next, I'll show you how experiences of acceptance and rejection impacted views of the peers themselves, based on a change in the ratings of the peers from before to after the task. So what we found was that older participants were more likely to increase ratings of peers who accepted them and decrease ratings of peers who rejected them, whereas younger participants didn't really adjust peer ratings based on feedback. So what I've shown you so far is that adolescents and adults did very different things with the feedback they received. Adolescents internalized rejection and experienced a drop in self-views, while views of peers remained unchanged even after being rejected. And in contrast, adults use feedback to enhance their self-views and externalize rejection by downgrading the views of the peers who rejected them. And I then examined neural response to peer feedback to help suss out whether acceptance and rejection were being weighted differently. In the interest of time, I'm going to skip those findings, but we do find brain activation that supports these processes. And so together, these findings support a broader framework to think about how social feedback is processed across adolescence. Adolescents are highly motivated to receive peer feedback, but this comes at a time when their self-esteem is particularly impacted by peer rejection. To make matters worse, they don't use self-protective strategies to buffer the effects of rejection like adults do. And while these tendencies are normative and likely adaptive in the service of social learning, it's important to highlight that this may also have some unintended consequences given the known links between rejection and clinical risk during adolescence. So this work establishing adolescence as a vulnerable period due in part to social sensitivity has served as a foundation for the next section of the talk, where I'll show you how adolescent social sensitivity relates to clinical risk, and more specifically, how it functions as a mechanistic pathway linking exposure to stress to mental health problems. And I'm actually going to kind of speed through this next study to get to the future directions, which I think many of you will be especially excited about. So really quickly, while for me, a cue of belonging was a photo shoot, teens today are absolutely inundated with these cues around the clock due to their constant connection of smartphones, and the intensity of these social cues persist even through digital means. Peer rejection and conflict can now reach further than ever before, following kids from school into their homes, right? And this matters because most of the stress that teens experience have to do with interpersonal stress like peer conflict or a breakup. And these social stressors are normal and likely important for development, as I mentioned before, but they still have an impact on mental health for many. And stress is a well-established risk factor for anxiety and depression. This coupling is actually especially tight during adolescence. In fact, most mental health problems, as I said before, arise in the aftermath of a social stressor. And this can likely be facilitated or even reflected in mobile phone use. So we can leverage new tools using mobile phone data to provide a window into the real world behaviors of adolescents, including social communication, which may be a pathway through which these social stressors come to increase vulnerability for psychopathology. So instead of going through this whole study for you all, I'm actually going to zip right to the finish line. We essentially examine social communication as a link between stressful life events and internalizing symptoms, which is another way of saying depression and anxiety. We did this in an intensive longitudinal study over the course of a year in 30 adolescent girls aged 15 to 17, but this got us a lot of sampling data, and we had continuous passive collection of mobile phone data. Again, what we did was we tracked each individual over time to look at fluctuations within person instead of just comparing one person to another. What this looks like across the whole sample is this. You can see there's a lot of intra-individual variability. That means the extent to which this behavior and these data really fluctuate within person. So we're talking about from 1 month to the next within the same person. And what we found, I'm going to skip through these right to the end, which is that what we found was that the number of incoming calls actually mediated the link between events and anxiety, stressful life events and anxiety, where the more stress someone experienced and more than normal, the more incoming calls they had that same month. And in turn, the more anxiety they had a month later. Now, and this explained about 40% of the link between stress and anxiety. Now, this was actually a surprising finding because we would have expected that phone calls would actually create a protective type of buffer for adolescents, presuming it reflects something like social support. However, it actually exacerbated the relationship between stress and anxiety. And one reason that we examined in our own data is that increase in phone calls tended to correlate with co-rumination. So ruminating with another person over the phone, in other words. And so that might be one avenue that explains this relationship. However, we do really need to examine the nature of communication. This study, brought us some answers, but actually created more questions than it did answer for me. And it really inspired this next future line of work for me that I'm going to just breeze through as well, where we're really interested in breaking down mobile phone use to understand who's it with and what's the nature of it. So I'll just move along. I'm going to skip what I can speak to also as we examine social factors that promoted resilience during the COVID-19 pandemic. Happy to speak to that down the road. But truly what we are really excited about going forward is this digital phenotyping arm of research. And in my current work, we continue to build upon these methods that I've already talked about. And we really are excited about leveraging machine learning using skills from and techniques from our close collaborator at Curry College. This is Varun Mishra. He's a professor of computer science. He runs the UV Well Lab, and his graduate student Akshat. We are developing an algorithm to track smartphone data and actually allow us to predict states of psychological vulnerability and resilience. We hope to leverage that information and then feed it back through to the study to help enhance resilience in adolescents. So the upcoming study that's NIMH funded is again an intensive longitudinal study where we sample teens monthly. We also get continuous data on their emotional well-being, their social behaviors, their mobile phone use. We're getting physiological data from their smartwatch. We ask them questions as they make their way throughout their lives about how they're feeling, their social behaviors. And as I said before, we're going to use machine learning algorithms to actually trigger a brief survey to their phone when they engage in smartphone behavior that's indicative of risk. And we then ask them about their phone use. So we get to these more difficult to ascertain constructs like what's the function of this phone use? So we're not just collecting things like how long were you on your phone, but what's the purpose of this use right now? These are questions that are not really being asked in the literature, in the field at the moment, even though there's a lot of discussion and interest about teens and mobile phone use. So happy to talk about this study. We're really excited about it. And we're really excited to bring on a whole host of collaborators from Northeastern and beyond to examine also how all this data relates to music, how teens use music to change their emotional states, how they use it to connect to other people socially, how they use it to define their identity. We're also examining misinformation, political identity development, polarization. We're examining vulnerability to misinformation during adolescence, the development of cultural identity, and sleep. So really excited that this upcoming study provides a great framework for bridging into other related disciplines that all revolve and are in the service of understanding the adolescent experience and ultimately how to build resilience in teens. So with that, I will just thank my previous collaborators and my current lab. And it turns out we will hold on to questions, I believe, until after the next speaker, my esteemed colleague, Dr. Sue Whitfield-Gabrieli, and thank you all for listening.
Well, thank you, Alex. That was a remarkable talk. I just love hearing about your research. It's just phenomenal. And I get so excited every time I listen to you speak. So thank you for that. I'm going to talk a little bit more that just really relies a lot on what Alex just told you about in the context of how we may be able to treat people who are already identified as suffering from anxiety, depression, psychosis. And specifically, I'll talk today about how we might be able to help people learn how to modulate their own brain networks. So I'm sure many of you have either know people in your family or friends, or somehow you're associated with people who may be suffering from mental illness. As you know, the U.S. Surgeon General and many leading pediatric health organizations in the U.S. as well as in Europe and other places all over the world have declared a state of emergency in mental health. And so there's really an urgent need for innovative personal treatments that target core mechanisms underlying mental illness. And I would advocate that there's been a tragic increase in mental health way before COVID. In fact, this is a nice paper from JAMA Pediatrics showing that there was a 100% increase in ER visits for children who are suffering self-harm and suicidal attempts way before the onset of COVID. But of course, COVID just spiked many mental illnesses, including anxiety and depression. And again, this has been highly documented in the New York Times, but many other popular press has been discussing it, but many people have not been discussing how we can actually help these kids. And so today I'll talk a lot about that. Specifically, how can we address some of the critical barriers that are preventing us from moving the needle in mental health treatments? And I'm going to highlight 4 here. I'm sure there's many more, but the 4 that I'm highlighting here is that the mental health care system right now is still based primarily on remediation instead of prevention. Treatments are done primarily with trial and error, despite the fact that there's a real great heterogeneity in treatment response. And thirdly, they just don't work that well. There's the gold standard treatments, both pharmacological treatments and behavioral treatments are effective for only 30 to 50% of patients. They often have negative side effects, and of course, there's a high attrition consequently. And fourth, the mechanisms of mental illness and the mechanisms of the treatments are fundamentally unknown. So today I'll talk a little bit about how we might be able to use human brain imaging to start to chip away at some of these critical barriers, specifically in the context of neuroprevention, neuroprediction, neuromodulation, and neurotriggering. So this will take an EPIC approach. First, we need to use these multimodal brain imaging technologies to be able to identify early in young children brain-based biomarkers that predict the developmental trajectory of symptoms related to anxiety, depression, ADHD, autism, and psychosis. And in that way, we can potentiate early interventions and possible mitigation of symptom progression, as well as onset of the disorder. So here I'm showing you an example of where we used the intrinsic functional architecture of the brains of very young children, age 7, that predicted the developmental trajectory of symptoms related to ADHD, anxiety, and depression years later. In addition to early detection, we need to also be able to use brain imaging to predict who's going to respond to what particular treatment. And in this way, we can gear towards precision psychiatry. So here's an example below where we had individuals who are suffering from social anxiety disorder, and they received 8 weeks of cognitive behavioral training. But at the onset, we didn't know who was going to respond and who wouldn't. So what we did was we had paper pencil analysis of their initial anxiety, but we also did brain imaging on these patients, and we were able to increase the predictive validity of who is going to respond to the CBT with a 5-fold increase. So we looked at the intrinsic structural functional architecture of the brains of these individuals, and we were able to greatly improve the prediction of who is going to respond to this particular treatment. And in that way, then we can, in the future, tailor particular treatments to the individual. We can also develop innovative treatments. And in other words, we can use brain imaging not only to identify biomarkers that predict treatment efficacy, but we can also modulate these biomarkers, which are plastic. And today I'll talk to you a little bit about how we can use real-time fMRI neurofeedback to modulate our intrinsic networks. And also, we want to be able to use neuroimaging to elucidate causal mechanisms. For instance, we're now developing a closed loop system whereby we can track individual fluctuations of symptoms and their brain and physiological antecedents so that we can trigger just-in-time adaptive interventions. Similar to what you heard earlier, being able to look at individual fluctuations of symptoms is critically important to be able to help individuals on an individualized basis. Understanding causal mechanisms, of course, then helps us refine treatments and interventions for the very specific individual and help tailor the treatments going forward. So what do I mean by neuroimaging? Here we have, right in Northeastern, we have 3 Tesla MRI. We can put patients into this MRI, and then we can look at brain structure and brain function. And with brain structure, we can look at MRI, brain function, we can look at functional magnetic resonance imaging pictures, but we can also look at the structural and functional intrinsic architecture as elucidated by diffusion tensor imaging, as well as resting state functional connectivity. And today I'll talk to you a little bit about what we call resting state functional connectivity. And that is if you have people just lying in the MRI scanner, what we can look at are intrinsic functional networks. And these are extraordinarily low frequency fluctuations of the fMRI bold signal that exhibit coherent networks in the absence of any task. So in the old days, we used to have people on the scanner doing cognitive or emotional tasks, and we would identify specific regions of the brain like the amygdala that would be responsible for a particular thing like fear. But now what we're doing is we're looking at large scale intrinsic networks in the absence of any task whatsoever that actually are very, very informative in terms of psychopathology and cognition. So here I'm showing you some iconic intrinsic resting state networks. And what you'll see here in red are regions of the brain that rise and fall in temporal synchrony in the absence of a task. So here you're looking from the top down of a person's brain. And you can see this is the front of the brain and the back of the brain. And even though these regions are anatomically very far apart, the functional architecture is actually intrinsically dynamically coupled. So these regions, although far apart spatially, rise and fall in temporal synchrony. And individual differences in the function of these, the structure and function of these networks shed great light into brain health and brain disease. And so luckily, these brain networks are plastic and can be modulated by behavioral and pharmacological interventions. In fact, what we found is that these entire large-scale networks themselves can be actually targets for neuromodulation. And we call this, it's a kind of a new field called network therapeutics. And we basically have people lying in a scanner, and we train them to modulate their own intrinsic networks through real-time fMRI neurofeedback. And rather than just looking at a particular region of the brain that we think it might be identified for a particular emotion or clinical symptom, we're identifying and targeting these large-scale networks that have significant downstream effects on cognition and behavior. And we believe that the ability to modulate the neural dynamics on a network level, as opposed to an individual level, an identified particular region, may be a much more effective model of neural regulation than modulating a particular single region or anatomically unspecific pharmacological interventions. And so what you'll see here is people basically look at a visual display, which I'll describe in a little bit. And then we basically train them to modulate their internal networks by modulating this visual display. And this gives them a sense of agency. So one particular network that we've been focusing on is called the default mode network, which was initially identified through the use of neuroimaging, I might add, by Mark Reichel. And Randy Buckner and many others have shown that this particular network is very much related to psychopathology in many different disorders. And recently, there's been an article by Henry Nasala suggesting that maybe the contemporary mental health crisis that we're all witnessing right now may simply be due to a default mode network disruption. Maybe this wide-scale attention, anxiety and depression that we're seeing that's hitting so tragically our teenage and even young kids, maybe this is a default mode network problem. And I believe that this could be a large part of it. And luckily, these networks are plastic and can be modulated not only by very invasive technologies, but also by behavioral technologies. So if we dive a little deeper and look at what this network consists of, we can see that here's a medial slice. So if you were to cut the brain in half, you can see the front of the brain here and the back of the brain here and the midline. The regions that I'm highlighting here in black are the regions of the brain that rise and fall in temporal synchrony. And these two core medial hubs happen to be specifically related to self-referential processing whenever we're thinking about ourselves. And you've heard a lot about that from Alex already, that this happens a lot in teenage years. And if we're in a normal state of mind, we may be reminiscing about the past or maybe, planning for the future. However, if we're depressed, the reminiscing of the past may convert into rumination about the past. Or if we're anxious, then thinking about or planning for the future may turn into obsessively worrying about the future. In other words, these two core medial hubs of the default mode network are over-engaged in many different psychopathologies that especially happen when you're engaged in some kind of mental time travel. And we and many others have shown that the degree to which these regions are correlated over time significantly relate to the degree of psychopathology one might have. In addition to which, these two regions are negatively or anti-correlated to all the regions that you see here in blue. And what I mean by negatively or anti-correlated means that if you look at the time course of the front and the back of the brain, say in these two red regions, they're practically superimposed. And like if you were to think of an orchestra, these two violins may be practically superimposed. However, if you look at any region in blue, they're actually negatively or anti-correlated. And it turns out that the degree to which these two networks are anti-correlated shed great light in cognitive performance. So one hypothesis that we have is that this default network we know is related to ourselves, our inner world, when we are engaged in mental time travel, be it reminiscing or rumination or thinking about the future or obsessively worrying about the future. These two core regions are over-engaged. And we believe that this is a targetable transdiagnostic mechanisms underlying many different psychopathologies, including mood and psychotic disorders. So not only that, but these two core medial hubs rope in very specific regions that might be related to a particular disorder, like say schizophrenia. For instance, in schizophrenia or other psychotic disorders, these two regions rope in something called the superior temporal gyrus that imbues self-relevance to auditory hallucinations, is one hypothesis that we have. Then also the degree to which these two core nodes of the default mode network rope in something called the anterior cingulate or the subgenual anterior cingulate is related specifically to depression and bipolar and may be related to internalization and anxiety and depression. So we find that these two nodes and their correlates are hyperactive and hypercorrelated in many different psychopathologies. And that this hyperconnectivity actually precedes illness. So we can actually identify this biomarker way before the onset of illness. In other words, these neuromarkers may represent a biological trait of the disorders rather than manifestation of the disease. So that's one way to think of this hyperconnectivity or overactive default mode network. But another proxy for this overactivity is this reduction of the anticorrelation. So this is another transdiagnostic targetable biomarker that we believe is related to cognitive impairment across many different psychiatric populations, including but not limited to ADHD, depression, and many psychotic disorders. So specifically, if we're looking at the degree to which the medial prefrontal cortex here and the dorsolateral prefrontal cortex here, the degree to which these are negatively or anti-correlated seems to be related to cognitive performance. So this connectivity, the magnitude of this difference seems to selectively increase through development as executive function. It peaks at early adulthood and then falls off in aging, healthy aging. And so you have this inverted U curve, if you will, over the lifespan of the human. And then what you'll see in many different psychiatric populations who suffer from cognitive impairment is that this anticorrelation is reduced, significantly reduced. And the more cognitive impairment you have, the more significantly reduced it is. It's even a proxy, we think, for consciousness. So if you give somebody anesthesia, you can see these anticorrelations start to diminish and come back as people recover. You can see disorders of consciousness, that these anticorrelations come back when people slowly recover from disorders of consciousness. And the baseline anticorrelations even predict who can come out of a coma. So this is really interesting way of looking at consciousness and cognitive impairment. So there's many different ways that we treat mental illness, and some are more invasive and some are less invasive. And so some of the more invasive technologies are something called deep brain stimulation, where you actually literally go in and invasively put in a deep brain stimulator, in which case it can alleviate this default mode network hyperconnectivity. Other people use ECT, you've heard about before, which is still very much used and very significantly related to reduction in symptoms in many different populations like psychosis and depression. But there's also transcranial magnetic stimulation where you can put TMS, the dorsolateral prefrontal cortex, or the region on the cortical area of the brain, that also mitigates this hyperconnectivity. Or there's a new interest in psychedelics or ketamine that also does the same thing. It reduces this hyperconnectivity of the default mode network. And then, of course, you have the traditional antidepressants like SSRIs. Again, really what you're doing is you're down-regulating this hyperactive default mode network. So if you were to look at the literature and you looked at the before and after brain network structure and architecture, what you'll find is that all of these invasive to less invasive technologies are really targeting the same network in many ways, and that's this default network. It's really unlocking this hyperactivity or hyperconnectivity, if you will, that relates to significant psychopathology. But not only do you have drugs or ECT that you can do, but you also have things like exercise and mindfulness meditation that also has the result effect of down-regulating this default network. But interestingly, let's say you take, for instance, TMS. So you're basically putting an electromagnetic field on the cortex here. What that's really doing is it's going deep into the brain and it's down-regulating this hyperactive default mode network. But that region and that network connectivity that is related here can actually be found very early on. So you can wait until you're an adult and get TMS to the brain. Or what we've shown is that teens with anxiety and depression, actually, the degree to which this deep brain and cortical region are correlated actually predicts worsening of anxiety and depression in teens who are already afflicted with anxiety and depression years later. Even people who are at risk for depression or anxiety but aren't actually diagnosed, that same biomarker predicts worsening of depression 3 years later and even predicts who's going to actually get depression. And even earlier, in normative pediatric at age 7, we were able to use the same biomarker to predict the worsening of internalization of anxiety and depression. So yes, we could wait until we're adults to actually get more or less invasive stimulations, or we could target really early on and put the fluoride in the water, if you will, and mitigate symptom development at the onset and perhaps prevent onset to illness. Ideally, you'd want to do that with a less invasive way. And one of the less invasive ways is mindfulness meditation. We know that it downregulates the default mode network. It increases cortical fitness, increases GABA, BDNF, And we know it helps many different patients with different psychiatric disorders. And we've shown in the Boston Charter School that if you were to give mindfulness meditation to 6th graders, you can actually significantly reduce stress, self-perceived stress, which is correlated with a reduction of the amygdala activation and connectivity, and it increases sustained attention with an increase in default mode network anticorrelations. So we've shown this in a randomized clinical trial already, and I would advocate that we should be doing this across the board and that we should have policy change to get this mindfulness meditation into schools younger and younger. Moreover, others have shown that mindfulness-based stress reduction is just as good as SSRIs in the treatment of anxiety disorders, and the clinical effectiveness and cost effectiveness of mindfulness-based cognitive therapy strategies it can even outperform CBT in people with depression. So these papers have been published in very high quality journals. There's more and more evidence that mindfulness really works. The only problem is that there's no feedback, and the very people who need it the most may struggle the most to actually sit quietly with themselves to actually practice mindfulness meditation. So we've developed something called mindfulness-based real-time fMRI neurofeedback. The neurofeedback mechanism is training wheels, essentially, to augment skill acquisition and utilization of this mindfulness technique. And so basically what we do is we have teens with anxiety and depression practice mindfulness meditation and adults with psychosis. We train them how to do mindfulness meditation outside of the scanner. We put them inside the scanner, and then we identify their default mode network and attention network. And then as soon as we have them start doing mindfulness meditation, that down regulates the default network and up regulates their attention network. We convert this fMRI signal into a game. And this is a ball game here where you can see the white ball. And the patients are playing the ball game in the scanner. So it's being projected back to them in the scanner. The idea of the game is that you want to push the ball up into the yellow circle, and the ball moves when you're successfully engaged in mindfulness meditation, therefore suppressing the default network and increasing your attention network. And the ball moves with a hop size proportional to the magnitude of the difference of these networks. So basically, the patients are in the scanner playing a ball game, moving the ball through the brain modulation. So they're moving the ball with their mind and their brain. As soon as the person or the patient starts to mind wander, the default mode goes up and the ball goes down. So they're moving the ball up and down. And what we find is that this is a non-invasive, very personalized, network-driven, and it's adaptive. So it meets the person where they're at. It's not just a one-size-fits-all. If they're struggling, we change the hop size of the ball. And most importantly, it promotes agency. When we talk to people who are suffering from psychosis, they love it because they can see how they're modulating their own networks, and they subsequently have fewer and less severe hallucinations and delusions in the case of psychosis, and in the case of rumination and depression. And so this promotion of agency, I think, is non-trivial. Oftentimes, when you think about treating people who are suffering from mental illness, the patients are usually at the receiving end. So they may receive deep brain stimulation, TMS or whatnot, or SSRIs. But in this case, we're flipping the situation such that the patient is actually the actor in his or her own play, where they're the ones modulating their brain networks, and they're the ones modulating their experience and navigating the world. So we find that agency is actually a critical aspect of this. So we've tried this in the case of schizophrenia, which we know schizophrenia has a high comorbidity with anxiety and depression. We've seen this across the lifespan and many different samples. And so I'm just going to show you a quick movie. This is where a patient with psychosis is moving the ball with his mind or the brain. And you can see here, right at this point, this patient is starting mindfulness. So you can see he pushes the DMN, the default network, down. That's in green. And because he's doing that, the ball is going up. You can see there's a difference between the attention network and the default network. And so he's able to get the ball up into the yellow circle, which shrinks to make the task dynamically more difficult. So in the end, what we want to see is a large-scale functional network modulation due to this intervention. And we do see that, such that we get a reduction of this hyperconnectivity after this intervention, and we get an increase in the anticorrelations. We don't see this if we have some kind of control region like the motor cortex. Ultimately, we do see reduction in hallucinations and delusions, and the degree to which we're reducing the hallucinations significantly relate to the reduction of this hyperconnectivity of the default network. We've looked at depression in the same way. We know that depression, the default mode network ropes in this highly relevant region called the subgenual anterior cingulate. And we see this in teens, we see it in kids, even in children who are not diagnosed at all. We see the degree to which the default mode network ropes in the subgenual anterior cingulate. It is correlated to internalization and anxiety and depression in young children. Again, not diagnosed with anything, just a familiar high risk. So this hyperconnectivity of the default network with the subgenual ACC exists very, very early on. And so we have these kids and teens in the scanner, and we're showing them how to modulate through real-time fMRI neurofeedback this brain connectivity. And here you can see an example of the before and after. This is the mean connectivity before and after for the default mode network and the default mode network and its relationship to this subgenual anterior cingulate. So these are just 9 subjects. So each time after this intervention, they significantly decrease this connectivity, as well as decrease the connectivity in its relationship to the subgenual ACC. So for future directions, we're trying to get early and earlier identification. We're working with Eden Evans, who's the director of addiction over at MGH, and who's sampled 50,000 kids around Massachusetts for being at risk for addiction. And in that survey, we see things related to repetitive negative thinking. And we want to go into the schools and be able to offer mindfulness, and with a subset of them, mindfulness-based real-time fMRI neurofeedback, so that we can help these kids and catch them before they fall. We're also working with colleagues at Yale to help people who are doing dialectical behavioral training, people, for instance, with borderline personality disorder, see if this real-time neurofeedback can augment skill acquisition and utilization of the mindfulness module. We're also scaling this intervention with EEG, so we have simultaneous EEG fMRI. So when they're doing this ball game, we can passively record the physiology, and in that way we can then scale it to the real world. We're also elucidating mechanisms to look at GABA and glutamate and how that GABA and glutamate changes with the network structure. We're also working with Columbia University to do a large-scale intervention to look to see to what degree this real-time neurofeedback is helping teens with depression mitigate rumination. So we're doing mindfulness versus mindfulness real-time neurofeedback. And we have another study in China looking to compare how does this mindfulness neurofeedback compare to TMS or transmagnetic stimulation. And we're also comparing it to exercise. In the end, what we would like to do is to go to the individual and identify how our physiology, how our heart rate and brain dynamics is related to individual fluctuations of things like repetitive negative thinking, which include rumination or worry, so that we can identify on a person-by-person basis when that person is going to be in an optimal or suboptimal state, so that when that person may have an auditory hallucination or a suicidal ideation, so that we can intervene early with just-in-time adaptive interventions. So I just want to mention that all of these treatments require a lot of methodological innovation. We develop these neuroimaging tools in the service of just helping people, but it does take a lot of development with the help of machine learning and AI. We're doing better and better jobs. So I just wanted to thank my colleagues in the Center for Cognitive Brain Health, including Alex and all the rest of my lab. Thank you very much.
Thank you so much to you both. Just fascinating information and fascinating work that you're doing. And clearly just so much for folks to think about. And I really enjoyed the information. I hope everyone else did too. We do have a couple of minutes for questions. One of them admittedly is my own, but Dr. Rodman, when you were presenting, it kind of, made me think of what I've heard lately about just in general, puberty in youth has started earlier and earlier over the years. And so I wondered, has the age for mental health changes kind of followed that same path? And Danielle Hutchins had a related follow-up question related to exposure to social media. And if that earlier exposure, especially during COVID, has had an impact on what we've seen in the age of onset of mental health changes as well?
Those are great questions. Actually, just recently, one of Sue and my colleague in the psych department, Heather Brenhouse's lab and work was just featured. She studies rodent models of puberty. You may have seen this article, but it's well established in the literature in both rodents and in humans that early life adversity, so stress can bring about the onset of puberty earlier. And so there is a relationship there. And then there's also a relationship between early onset of puberty and mental health problems, especially in girls. And all of those effects are quite complex in terms of what both brings it on and the context in which it happens. And so there's likely a biological underpinning of that, but also a social one where girls who are developing earlier, and this is with boys too, you're kind of treated as older than you're kind of like cognitively able to act as. There's also a lot more of like attention to girl bodies that are developing earlier. And so those are some of the social aspects that can happen when you have earlier development. But then there's also these downstream effects from biological consequences of early development, especially if it's brought on by this early life stress. It can affect the entire physiological response to stress within the system. So we know that. In terms of your question for the social media component, yes, a lot of discussion around this as of late. It's an old question that has been very hotly debated in the field really since 2015 or 16, when Jean Twenge really brought attention to this correlation between smartphone use and mental health problems. People who've been in this field for a really long time agree that the science has really not been there yet. It's still really coming online to be able to more granularly or more specifically understand how smartphone use relates to well-being. What we do know is that teens who show symptoms of depression or risk for depression, any kind of behaviors, they use their phones differently. So it's actually almost like a reverse direction in terms of how depression, for example, and smartphone use relate. It's not necessarily smartphone use causing symptoms. It's more likely than not symptoms causing a different type of smartphone use. Another thing to keep in mind is that smartphone use and social media in particular may be particularly harmful for some kids. So there's some research that shows that particularly vulnerable kids, not just in the symptom domain, but kids who have predisposition for risk are the ones who are particularly impacted by it. So really the name of the game is, up to this point, we actually don't have a lot of science that can speak to the effects of smartphone use and particularly social media use on teens, but we do know it's very nuanced, it's very complicated, and there are threads that connect to what in our gut we feel to be true, that some kids are being impacted by it. But there are open questions about directionality. That being said, there are probably some common sense limitations that can be put into place, whether that's in schools, or there should be recommendations for families in the home. That's going to vary a lot by family. There's also research, this is the last thing I'll say, coming out about parent use of smartphones impacting kids more so than kids' own smartphone use. So that's another thing that we actually hope to study with our upcoming study, is we're also going to passively sense or collect data from parents' smartphone use as well to try to disentangle source. So that's what I'll say there. Thank you for the question.
I have actually, as a parent myself, heard something around that last piece and felt very guilty afterwards. And so I'm looking forward to hearing more about that. Do folks have other questions? Feel free to either put them in the chat, or I think we've got a good size of group where if you'd like to unmute, that's fine too. Super. Well, we are right at 1 o'clock, so that is great timing. Again, thank you so much, Dr. Rodman and Dr. Whitfield-Gabrieli. This has been such a pleasure and so fascinating and inspiring to hear about the work that you're doing, the research that's being done. Another special shout out to Kira Green and Gabby DeStefano, who also had some behind the scenes help in putting this webinar together. And again, thanks to all of our attendees who joined us today. We have recorded this session, so we'll get it up on YouTube and send the link out to folks if you'd like to watch again. Again, Gina Reganini from Alumni Relations, thank you so much for joining us and have a great rest of your week.
Thank you.